Hello, everyone. A very warm welcome of you. I'm Lucrezia Furian. I'm currently the chair of EKITA. I'm a professor of surgery at the University of Padua. I was trained in Padua, in Italy, and in the United States. And among my research and clinical activities, I will talk you today about kidney donation. Um, I will talk about a very special kind of pair donation, which is the deceased donor initiated chains. I will first introduce the concept of kidney pair donation, try to go into the details of what we mean with exchanges and chains, and then I will focus on the deceased donor initiated chains. First of all, we have to keep in mind that several patients have a willing donor, living donor, but for them it's not possible to proceed with the transplant. This can happen because they have ABO incompatibility or HLA incompatibility. For those patients with incompatibility with the donors, we can proceed through desensitization. We can put them on a waiting list for a deceased donor, and there are several programs all over Europe to accelerate transplantation for patients highly sensitized, or we can offer kidney pair donation. There are several different terms to define kidney donation. The most used is KPD or KPE, kidney pair exchange. If you look at UK, you will find that the same concept is expressed as kidney sharing scheme, and in Italy, for some reason, we use the expression crossover. The first published paper on this topic was done back in 1997 by the group of Chicago, and they were trying to explore the legal and ethical framework of kidney donation. What was envisioned at the time was the so-called two-way loop, where a donor with an incompatible recipient was available to donate to another recipient who had an available donor but incompatible, but willing to donate to the recipient of the first pair. In 1997, we have seen that they were working on the legal framework, but in 1991 in Korea, they started doing it, and they published the first series of cases. There were 61 cases of kidney pair donation. This two-way loop, this two-way exchange, it's very easy to understand when you're talking about blood type incompatibility, because if you have a type A donor, type B recipient, you can make a switch, and the type B donor of the second pair can donate to the recipient of the first pair, and the donor of the first pair can donate to the recipient of the second pair. But this situation becomes much more difficult when you have a positive cross-match, when you have an HLA incompatible pair. For these patients, it's quite unlikely that you may find the reciprocity which is needed to proceed with the swap, because even though the donor of the first pair might be compatible with the recipient of the second pair, it's very unlikely when you have this large number of incompatibilities, it's very unlikely that the donor of the second pair can donate to the recipient of the first pair. That's why the so-called domino pair donation were started, and now we start talking about chain. The domino pair donations can happen when there is an altruistic donor available to donate with a recipient. If this recipient has an incompatible donor, the chain can proceed, and it can either end to a recipient on the waiting list or can become a so-called bridge donor and become the start of a new chain. In this case, we talk about non-simultaneous extended altruistic donor. The first net chains in Italy was done back in 2000, 15 and allowed to perform 6 transplants. The main point of doing this kind of very successful program to have altruistic donors. Unfortunately, over the last 7 years, only 8 altruistic donors became available in our country. And this situation is very common in other countries. Somewhere it's very it's very successful, the opportunity or the availability of altruistic donors. In some other countries, it's either forbidden by law or it's not culturally very acceptable. So although it's very successful, the chain, starting with altruistic donors, the numbers tend to be quite low in several places. That's why we have merged the program of kidney pair donation with the deceased donor altruistic donors. We have to consider that whatever deceased donor is altruistic. And if we have a good quality deceased donor, we may consider them be able to start a chain just in the same way we do with an altruistic living donor. And here we go into the detail of the topic of my talk, the deceased donor initiated chains, or DEC. The idea started back in 2016 in the paper published by Melker, and it was just an idea, but we were able to transform this idea into a policy. In 2017, in the United States, they have written a very interesting paper where they analyzed different points of this program. What should be the characteristics of the candidate, of the donors, and the timing of these procedures. If we decide that the recipient is placed on the priority on the waiting list, and subsequently the donor becomes available to donate or donates, we do this kind of program. But if the donor donates first and the recipient is subsequently placed in the waiting list as a prior recipient, we talk about list exchange. List exchange was done several years ago in the United States, UNOS Region 1, and they have performed a series of cases where the recipients were transplanted after their donor donated to someone else. But as you can see in this experience, the main reason for incompatibility was ABO incompatibility. For patients with high PRA, the length of wait to obtain a kidney was quite long. What is different in our case is that we decided that first the recipient is placed in a priority for transplant, and after his transplant, the donor donates. What are the characteristics of the candidate? Well, the candidate has a priority which is very high in our country. After the urgency program and the highly sensitized patients and simultaneous kidney and pancreas program, all the donors are considered available for the recipients in priority. We need to have ABO identity and or compatibility, and we consider unacceptable those antigens with an MFI higher than 3,000. We want to have a negative CDC and flow cross match. Talking about the donor, what are the characteristics of the donor to initiate a kidney? So the chain initiating kidney is to come from a donor of a standard risk with no severe comorbidities, severe hypertension, no diabetes, good renal function, and we excluded the DCDs. We first applied the protocol in March 2018, and you can find the reference here in transplantation. It was a very short chain, only one donor, one pair, and one recipient on the waiting list receiving the kidney from a living donor. Very quickly after that, the program became a national policy. So starting from November 2018, all Italian donors with adequate requisites must be considered for offering a chain initiating kidney. And all the patients who have incompatible living donors are offered the opportunity to participate in the DECT program. If we compare what happened in the kidney donation program and the DECT program over the years, we can see that 2015 it was possible to transplant 29 pairs in the kidney pair donation program. But if we consider that the DEC program started in 2018, we were able to perform 37 transplants, including 24 pairs, and we have used 13 chain initiating kidneys. And it's very important to consider that in the DEC program, most of the pairs were incompatible because of DSAs, because they had an HLA incompatibility. This policy became quite famous, and we have been invited in the United States to present, and they are very interested in starting this kind of project. And very recently, our friends from France, they say France, from France, they have shown their interest in starting this kind of program, and in their simulation they have seen an increase on the match from 20% to 50% using deceased donor kidney to initiate a chain. So I would like to conclude my presentation with a few sentences. Of course, DEC program should not be considered the only kidney pair donation program, but it's ancillary to the standard programs, and it avoids to accumulate sensitized patients. It's very important to consider that in some countries, kidney donation by non-directed altruistic donors prohibited by law or culturally not widely accepted. And for this country, DEC can be a good solution. But we have to consider that although there are some rules, there are some laws, it's always possible to change the paradigm, change the laws, to change the regulation. So I'm happy to show you this quote that I like very much from the philosopher from Greece. There is nothing permanent except change. So in several countries, the change should be considered in policies. And so let's make it more personal. I would say there is nothing permanent except exchange. For your attention.